Once a patient has been diagnosed with thyroid cancer, often on a fine needle aspirate, which is the first detection of the thyroid cancer, they're referred to a surgeon. And at that point, usually a surgical intervention is planned. And at that surgical intervention, usually the thyroid is removed most of the time in its entirety. Sometimes, very rarely, it might only be half of the thyroid is removed. If there's any possibility that there are lymph nodes that are involved, they will also be removed at the same time. But that's usually in the case that either on ultrasound they look like they were affected, or they may have actually been biopsied previously. So a patient will have both their thyroid removed as well as the lateral lymph nodes at that time. And then that provides pathologic information and confirmation of the full diagnosis of thyroid cancer. Sometimes it occurs that patients will actually be diagnosed with a thyroid nodule, and maybe it hasn't looked like it needs to be actually removed at that time. And so that nodule may be followed on ultrasound for a period of time. And at that point, one of the things that the physician will be looking for is how big is it getting? How fast is it growing? And also, where is it located? Is it staying inside of the thyroid, or does it look like it's starting to approach the capsule and might be getting in trouble there? All of these things would be worrisome signs that this is indeed not a benign thyroid nodule, but actually an invasive cancer. And these would all be signs that would then lead them to have a surgical intervention and have the surgery to fully evaluate what is actually going on with that thyroid nodule.
So the purpose of the diagnostic workup is to determine whether the patient might or might not have thyroid cancer, and if there is a very high suspicion for thyroid cancer, surgery will follow. And in fact, this surgery will give you the answer whether the nodule is malignant or not. So the purpose of the diagnosis is not to determine the risk of the thyroid cancer patient for dying or not dying from thyroid cancer. This is done after initial surgery. Having said that, when we have a very aggressive tumor that is large and grows fast, we are of course afraid that this patient might have metastases, and in those cases we will do more extensive diagnostic workup, including CT scans of the lungs, of the neck, and probably even more extensive imaging like FDG PET scanning and things like that. So if we have a patient with metastases or very aggressive local tumor, then we know that the prognosis will be worse. But still, those patients can be treated well with surgery and radiative iodide if those patients have differentiated thyroid cancer. So we can cure patients, for instance, with pulmonary metastases. So at this stage of diagnosis, it's very hard to have an idea about the prognosis of patients.